Today, I really have the honor of bringing in Dr. Stanley Goldfarb. He has been at Penn Medical, or to be exact, the University of Pennsylvania Perelman School of Medicine. For many, many years, he was the head of the Department of Nephrology, Kidneys. He became involved with the curriculum there, and needless to say, we're all of us as physicians very much involved with teaching. We teach students, we teach interns, we teach residents. We keep teaching, we teach patients afterwards. And he's been involved with this and recently left that position and formed a nonprofit called Do No Harm. What is the harm that he is trying to prevent? And what is going on in medical schools that many of you are not aware of? What is going on with admission criteria? What is going on with actually teaching medical students the science? Are they getting enough science, or are they becoming social justice warriors based on what the curriculum is? So I want to introduce you, but first I want to thank a number of people who have contributed to the cost of doing these talks. I'm not going to name names, but I'm just going to say a number of them are here. We greatly appreciate your contributions. I also want to thank Christine Rasmussen, who I have been communicating with from Do No Harm, and she'll come up and give some remarks as well. But for now, let me ask you to please welcome one of my heroes, Dr. Stanley Goldfarb.
Yes. Well, thank you so much. Can you hear me well in the back? Yes? Okay, if I start to trail off, Dr. Altman says I'm a little too soft-spoken. You'll encourage me to speak up. It really is wonderful to be here in this most beautiful place. I think the last time I stood behind the ark was probably it was somebody's bar mitzvah, I'm sure, but certainly my own. So I'm glad the Haftorah is not right in front of me to challenge me. But it really is wonderful to be here and see so many of you who are interested in this issue. He wants me to talk louder. Okay, here we go. So I was at Penn for over 50 years as a professor. I had a research lab. I was a sort of a typical academic position, as you heard, a kidney specialist. If you went on the website, you would see my picture. You could make an appointment to see me, etc. Today, if you go on the Penn website, my name is nowhere to be found. Nowhere to be found. If you look on the website of the renal electrolyte division at Penn, which is over 70 years old, there was a story of the history of the division and who led it. My name is nowhere to be found, even though I was a co-director of the division for several years. If you were a physician and you were aware of something called UpToDate, it's the most widely used online reference for physicians. Worldwide impact of this. I was one of the editors of the kidney section of it. If you go on to UpToDate now, and it's very useful for patients as well to get information, my name is nowhere to be seen, and no acknowledging of all the pieces for it that I had written. My name is in textbooks. It's hard to erase it from there. So what happened? How did this happen? And why am I here? And what's the basis for me being here and for starting Do No Harm? So I'm going to just tell you my story fairly briefly, and then we'll have a chance to take questions and this is like the baseball stadium. Very impressive. Thank you. That helps a lot. This all started back in about 2017. And I was finishing up almost a dozen years of being the Associate Dean for Curriculum in the medical school. I was responsible for the curriculum. I wasn't in love with the curriculum, but I had inherited a curriculum, and there are a lot of people that contributed to it, and I tried to deal with it as best I could. The woman who ran the education program at Penn, Gail Morrison, very good friend of mine, we collaborated for many years, and everything was fine. And we really weren't aware that much what was going on around medical schools in the United States. And the reason for that is that Penn was a very highly ranked medical school. We were ranked number 3, number 2. I think Harvard was always number 1, but we were right there, and we got wonderful students, and we thought that the students we were training were really excellent. And we were very pleased with ourselves, and we didn't see a need to go and adopt other schools' methods. And then one day, Gail was replaced as the Vice Dean for Education, and a new person came in, and this new person had 2 degrees. She had an MD degree, and she also had a Master's in Education. And let me just tell you that that is a clue to one of the great problems that's going on in the United States, is people that have been trained in schools of education, because they have become the hotbed of what really is a social transformation that's going on in the United States that's not really to anyone's benefit, I think. And she came in and she said, we have to really change this curriculum. This curriculum is, her famous comment to me that I've now repeated many times was, there's way too much science in this curriculum. I'll just let you think about that for a moment. So what was she really advocating for? She wanted us to start to create physician advocates for various social positions. What were some of the social positions? We had to deal with poverty. We should start having the students deal with food deserts in communities. Students should be much more aware of gun violence that's going on. Students should be much more in touch with climate change issues. Now, these are all important issues. These are all important issues for American society. But I sort of sat there and said, how in the world is a physician going to change any of that? Our job is to take care of sick patients. Our job is to be empathetic. Our job is to understand people's suffering and to help them deal with it. Cure them if we can, certainly comfort them always. And yet, this was now the new goal. And I sort of said, this is sort of ridiculous. I don't understand this. We can't do anything about these things. I had a faculty member that came who was very upset with me because we didn't have a course in climate change. Excuse me. I said to him, I don't have a degree in atmospheric thermodynamics, therefore I don't feel qualified to really talk about the climate and what its impact was. And I said, by the way, anyway, if the worst thing that happens is we have the climate of Miami up in Philadelphia, that sounds pretty good to me. Well, this went on for about a year, my being very upset with what was being suggested and implemented. And at that point, my position was reorganized. It's a nice way of saying I was fired. It was the end of my career anyway. I was ready to retire soon. And one day I saw an article in the Wall Street Journal that, excuse me, that said that 40 medical schools had courses in climate change. And I looked at that and I said, this is just ridiculous. And I wrote a letter to the editor of the Wall Street Journal. My son, who's in journalism, says people who write letters to the editor are basically insane, but nonetheless, I wrote the letter to the editor, and the editor came back and said, I don't know about this article, this climate change article, but why don't you write an op-ed? And I said, okay, and the focus of the op-ed, and now we're in September of 2019, just before the pandemic hit, the focus of the op-ed was the fact that the medical school curriculum was devoting more and more effort and more time to this issue of social justice, and was focusing more and more on creating students that are going to implement some of these social justice issues, become advocates. The article I wrote was about the curriculum. They accepted the article, and they put a title on the article, and here's where the trouble started. the title that they put on, and those of you that interact with journalists know that when you write something for an article, a newspaper, they put the title on, they put the headline on. The title was, "Take 2 aspirins and call me by my pronouns." Well, of course, there was nothing in this article that I had written about diversity or gender issues, but that was the title, and it was just an uproar over this. My school leadership read this, and they issued a statement to the Philadelphia Inquirer that my ideas do not represent the ideas of the school, that they believe in diversity, equity, and inclusion, and they resent my ideas, and and then I showed up at the school a couple of days later, and we were in the midst of starting the kidney course, and I always taught the students the kidney course. I ran it for several years. And they told me, "We're not sure that you should be teaching the students. It's dangerous for you to have you teach the students." Finally, they relented. I taught the students. Afterwards, they checked with the students to make sure that no one was harmed by my teaching about sodium and water metabolism. So I wrote that article, and then I decided that I needed to expand these ideas, because obviously I got a lot of people who wrote back and said, "Yeah, we're really glad to see that you're doing this." There's something called Med Twitter, which no physician should fall into. It's basically run by very young people. They were not happy with me, and they attacked me, but fine. I let it go, and I decided the next thing I need to do is write a book and flesh out my ideas more, which I did. I wrote a book. The publisher, sure enough, said, "I like that title of your article. This is going to be the title of the book." So that's the title of the book, "Take 2 aspirins and call me by my pronouns." And my book is really about what's happened to American medicine, what's happening to American healthcare, what's happening to medical education in the United States. And here are the issues that I really feel are the great concern here. There are minority populations, such as the African American community, that have really much worse healthcare outcomes compared to other groups, particularly whites or particularly Asians. And part of this push for changing the medical curriculum has been to accept the idea that sprang up almost out of nowhere when George Floyd was killed, that in fact, Black people are really being oppressed by white people. This is the nature of our interaction as communities, that white communities interact with Black communities in a form of oppression, that the Black people are oppressed, and medicine is an important tool of oppression. And that the reason that there are such disparities in healthcare outcomes is because Black people are being treated poorly by physicians, and that if we could only change that dynamic, outcomes would improve. Well, physicians in the audience here, I know there are many of you, and my own experience is, when I walked into a room and saw a patient sitting there, somebody with kidney disease, severe hypertension, dialysis patients, these are the people I dealt with, I didn't look at them and say, this is a Black patient, I gotta give them the Black patient treatment. It was a patient, it was a suffering patient. I had one patient, I remember, was a Tuskegee Airman. You think I looked at him and thought, I'm gonna oppress this man? It was absolutely ridiculous. And yet this has been the dynamic that's being proposed. And once you go down that path, then what do? You say, well, we have to change the way healthcare is delivered. We have to deliver healthcare in a different fashion to minority groups compared to white patients, because we've been hurting them in the past. Now, this is very pernicious. And the reason it's pernicious is because it's not true. And what really needs to be done is, to, in fact, to improve healthcare access for people. And we can talk about that after the discussion, rather than to change the nature of medical education and the way physicians are treated. And it just seemed to me that in order to combat this, which I feel is a very dangerous sort of idea, is that we need to start an organization and to mobilize people. And that's why Do No Harm started. We started in April of 2022, right after my book came out. And we set it upon ourselves really 3 approaches that we were going to take to try to fix American healthcare and medical education. One was we're going to try to inform the public. And we had wonderful donors who helped us communicate with public relations firms and individuals who could get our message out there. And we've now had over 2,500 hits, if you will, in the media about the issues that we really think are important, which is to combat this idea that healthcare is discriminatory to Black people and that we need to change the way healthcare is delivered in order to improve their outcomes. The second thing we did was we said we want to fight against these discriminatory practices that are going on. And what are some of the discriminatory practices? Well, again, it first sort of sprang up during the pandemic when it turned out that there were algorithms that were put forth in New York City and out of Utah that they were very scarce monoclonal antibodies that were first used to combat the COVID infections. And it turns out there were algorithms that said if you were a Black person and there was a white person in the room and there was a Black person in the room and they both were equally ill, the Black person was going to get the precedent for the treatment compared to the white person because race became a factor in determining who was going to get cared for. Now, if that Black person was sicker than the white person, absolutely they should get the treatment first. But if the white person was sicker than the Black person, delaying that treatment was really denying proper care to that patient. So we started to fight against this. Harvard Hospital, the Mass General Brigham and Women's Hospitals, came up with a protocol. They were going to treat Black people differently than white people if they came in with heart failure. They published a study on this. The study turned out to be wrong because what the study really showed was they were two different populations of patients. The reason they were treated differently is they had different underlying complicating diseases, not because anybody at Harvard was particularly biased against any group of patients. So we set about to fight back against these issues by informing the public. The second thing we did was we decided that we had to take a more aggressive legal approach. And in this legal approach, we decided to sue some people that we thought were acting in a discriminatory fashion. And the first lawsuit we filed, we took on the federal government. Now, it was quite interesting. As I flew here this morning, on my plane was Secretary Javier Becerra. And I wondered if he knew that he was on a plane with someone who had actually sued him. Because we had. And Do No Harm helped support a lawsuit that went against the federal government, and Becerra is named in there. Why did we do this? It's because at the end of 2021, the federal government put out a rule in Medicare that said if you were a physician caring for Medicare patients, you would get an incremental payment if you established an anti-racism protocol in your practice. Now, anti-racism is an interesting term. It suggests that you're going to be against racism, which I am, and I bet everybody in this audience is. But it also suggests that you buy into this idea that the nature of white and Black community interactions is this oppression, that's the nature of this interaction, and therefore you have to do something different. You have to treat Black people differently in order to fight this discriminatory practice that you've been engaged in all these years. And we had a bunch of physicians who said, this is terrible. I don't want to treat anybody differently. I don't want to have a protocol in my practice that's going to be different. And we ended up instituting a lawsuit. The lawsuit has been joined by 8 states' attorney generals. And this lawsuit is working its way to the federal system. And we understand that we're going to get a positive result out of this lawsuit, that this rule will be rescinded because this rule really is discriminatory. We filed some other lawsuits against Pfizer. Pfizer had a program, and the targets of these lawsuits, you have to be able to sue. First, you have to have standing to sue, and secondly, the basis for these suits is that the civil rights law said that you can't discriminate against people based on race, and we wanted to fight against what we saw as clearly discriminatory practices. So Pfizer had a program. It was a very rich program to bring employees in, to give them extra training, to give them all kinds of support. White people and Asian people need not apply. They had a whole list of people who could apply, but some people couldn't. This is not America. You cannot do that since the middle of the 1960s because we have civil rights laws. And we've launched other such lawsuits. We've done a lot of writing to the Office of Civil Rights, who there's an opportunity to simply write a letter. You don't have to have standing to have these letters written, to have schools not have scholarships that exclude people based on race. And I can't tell you, almost every medical school in the country has some sort of program that actually is racially exclusionary, and it really is illegal. And the last thing that we've done has been that we've pushed laws. Now, I'm not a big fan of the government having to get into the practice of medicine or even to run medical education. But we feel very strongly that what's going on in American medical schools and what's going on in higher education in general really is very discriminatory. What's being asked of faculty to get promoted at many schools is to make a statement that you're supporting diversity, equity, inclusion. Now, that may sound fine because diversity seems to be okay superficially, but what's being asked of these faculty members is to say, what have you done? How have you gone out and made changes in the community that's actually accomplished these goals that the school has? Well, that's okay, but the reason you hire faculty members at medical schools to teach medicine and to do research, and if someone's a groundbreaking researcher and they're really not spending their time on diversity, equity, and inclusion, they were going to have trouble getting promoted. And they had people on promotion committees that simply came from the Office of Diversity, Equity, and Inclusion. An office, for example, at the University of Michigan that costs $18 million a year. That's how many people are involved in the program there. So the laws that we've fostered in various states, Tennessee, Missouri, Kansas, other states in the Midwest and the Mountain West, has been laws that prevent these kind of discriminatory practices. If you're going to take people into medical school, take them on the basis of merit. Don't take them on the basis of skin color. If the entire medical school class at Penn were African Americans and they all qualified, fabulous, that's great. I have no problem with that. If they were all Asian, I don't care. If they were all Jewish, fine. I don't care. I just want the best people. I want to have colorblind medicine. I want colorblind medical school admissions, because to me, that's the only ethical way to pursue medicine. So Do No Harm has been very lucky because we've had Christina Rasmussen, who's been the most energetic and effective executive director, and she's been someone who has a long experience in the legislative arena. So I think we've been able to make a difference more because of this approach of, we're not going to just stand here and tell you things are terrible, but we're really going to try to change things. And I think we'll start to change things step by step. We've developed a secondary mission as well, and we can talk about it a little bit in this next portion, about the problem of so-called gender-affirming care and what the impact this has on medicine and on the American population. We can talk about that as well. And I'll just say the reason that we've adopted this secondary mission and used some of the tools that I just mentioned in that area as well is because I think in each case, what we're dealing with is this idea that human beings have to be defined by their identity and not by their individuality. So when you walk in a room and there's a black patient, it's not, there's Mrs. Jones. She has medical problems and social problems. I need to be conscious of these and deal with her as an individual. No, I have to see her as a black person who's getting this different protocol because they're black. And the same has happened with the so-called transgender movement. Kids are showing up and they're being told, yeah, you're a trans kid, and we're going to treat you all the same. And instead of finding out why this child is making these decisions and what's the basis of their psychological difficulties that have led him to this point, or not, or it represents the right thing for the child. That kind of exploration is not going on. So that's why we're taking on these dual missions, because we see the complementarity between them. Christina, do you want to come up and talk a little bit about the other activities of that? I may have screwed up the sequence here. I apologize for that if I have.
Thank you, Stan, for the introduction. My name is Christina Rasmussen, and I have the honor of serving as the Executive Director of Do No Harm. I live in Richmond, Virginia, with my husband and my 4 beautiful kids. And I'm not a doctor, but a couple of years ago, I opened up the Wall Street Journal one morning over my morning coffee, and I read this op-ed that said, take 2 aspirin and call me by my pronouns, and I was horrified with what I read. With 4 children, you can imagine, I am in the doctor's office a lot. My kids are really good at living life to the fullest, and we often need the attention of our pediatrician. And I was horrified to think that someday they might walk into a doctor's office and be treated differently on the basis of their skin color or their identity groups. And so when Stan reached out and said, hey, we're putting together this nonprofit, we'd really like you to join, I was thrilled because I was already sold on why this was such a critical mission. So my background is in public policy and advocacy. I got my graduate degree in political management from George Washington University. I have served as a lobbyist at the federal level, at the state level. I've run a state-based think tank. I served as chief of staff to a governor of one of the largest states in America. So my background is in nonprofit management and getting things done at the State House. So there's this really great interaction of Stan understanding the medical side of things and me being able to bring in the nonprofit, let's go get something done and change the world side of things. And we have put together just an incredible operation. I want to give you a quick vignette of how this has all come together in less than 1 year. We decided we needed to open up a tip line for people to bring to us situations that for some reason they felt that they could not speak up. Maybe they would lose their job and they couldn't pay their mortgage, or would threaten their ability to get a degree or a license. So we opened up a tip line and said, if you're seeing instances where medical education, research, or licensing is being corrupted by some of these forces, please tell us about it. And boy, did we open a floodgate. So many people came in saying, here are these trainings that I have to go through. Here are the things that I'm being forced to attest to in order to keep my job. Here's evidence of discrimination at my company or my university. Please help, can't you do something about it? And we've been able to develop an operation so that we can filter these coming in and figure out how to help people. Earlier this spring, into our tip line, we had someone from the state of Arkansas say, hey, the state is handing out scholarships and it's preventing white, Asian, and Arabic people from applying for the scholarship. And this is from the state of Arkansas. Isn't this illegal? Isn't this wrong? We have a great team of lawyers. They looked at it and they said, yeah, absolutely, this is 100% illegal. So we had a young person in Arkansas who was able to apply for this scholarship on the basis of the fact that this person was going to medical school, they lived in Arkansas and so forth, except that this person was not of the right color skin. This person became a member of Do No Harm. When someone becomes a member of our organization, any legal harm that they've experienced transfers to us. So we could file the lawsuit against the state of Arkansas on this person's behalf. They're anonymous and they will stay anonymous. But we were able to force a judge to look at it. The Attorney General of Arkansas looked at it and was like, yeah, this is pretty blatantly illegal. So we reached a resolution and they agreed to change the scholarship so it'd be open to everyone. This all happened within a matter of months. This scholarship had been on the books for years. What it took was for someone to say, this is a problem, here's how we can help you, and now let's go do something about it. So this is just one vignette of the things we're doing every single day to actually go do something. My daughter, who is in the corner, will attest to the fact that mommy likes to get things done. So this is just a really incredible way to not only bring attention to a problem, but to help change it for the better. So why don't I pause there, and I think you guys were to chat a little bit more about some of the gender things, and I'd be happy to answer any questions about the organization later on.
Thank you. Let's take this down. First question I'd really like to ask the audience. How many of you are aware of what you just heard before you heard it here today? Okay, so it's about 40%, maybe 50%. One of the important reasons that we bring people in to speak is because what we're finding with the media is that this stuff doesn't get around enough, so people are not aware of it. This is the medical profession. This is the people that we need to trust, who are taking care of us, especially those of us over the age of 60, and even those of us over the age of 100, who are sitting here and who go to physicians for care. I am a physician. I was an obstetrician gynecologist and then a gynecologist for many years. I still am here. When I started to hear about this, and I trained at Brigham and Women's Hospital, used to be called the Boston Hospital for Women, I didn't see color. I saw a patient. And I was listening to what physicians still at Brigham and Women's Hospital, who I still talk to quite a bit, what they were being asked to go through in training as far as DEI is concerned, what they were being forced to attest to, as you mentioned, and I was rapidly insulted. And I felt that, wait a minute, this is going in just the opposite direction of what Martin Luther King said. I mean, it's becoming, you have to see race, and I truly resented that. And unfortunately, that is what we are starting to see. I remember that as a physician in Boston, we have all sorts of patients, and every patient had a need. Now I'm looking at, just as an example, it's probably a poor example, I'm looking at the professional sports leagues. How come the NBA, the Major League Association of Baseball, all of these major athletic organizations, there's no DEI. These are professionals. They have trained long and hard over their lifetimes to become these professionals, to demand these wacko salaries nonetheless. But these are people who've worked very hard, not unlike physicians who work very hard, except for the salary difference, of course. What are the professional leagues doing? What are the people in football and basketball and baseball doing? What they're doing is they're going to communities and youth in community and teaching them and helping them and training them and giving them access to learning how to play whatever this sport is. That's the way you can do something. Not at the level of, oh, okay, now we're going to do the NBA draft and at least 40% of these players have to be white and 40% black. I mean, you're getting an idea of what I'm saying. The time to go to the community is early when people are young, when kids are young. Get them involved in this way. Can you comment on that as far as how do we help what is perceived as a problem here without bringing in people who are not adequately trained to learn medical science?
Well, I think, again, the way physicians sort of approach things is first we should make a diagnosis. And the question is exactly what is the state of medical education right now? What is the state of the cohort of students? 22,000 students enter medical school every year. What is the state of this group of students? So let me just go back to an era when Dr. Altman and I were in medical school. At that time, there was about a 9% attrition rate in medical schools. And the reason for that attrition was both psychological problems, family problems, but a lot of it is that the students couldn't do the work. Some schools were as high as 15%, some schools that were more selective in the students they took in were much lower. Now, attrition in medical school had been a big problem in the 30s, is why the Medical College Achievement Test was created in order to only accept students into medical school that could do the work. And the thing about medical thinking is medical thinking and standardized tests are very much in sync with each other. And why do I say that? It's because in standardized tests, you get a stem, which is the little story that is made up by the people who create the test. And they give you 4 or 5 distractors, it's called, to see which is the right answer. And that's the way the Medical College Achievement Test works. That's the way the SAT works. Well, I tell the students, I used to tell the students, in medical, as you become physicians, as you go into the clinics, You are now going to be the ones who write the multiple choice test. You are going to create the STEM, which you're going to create by getting the patient's history and identifying the key factors and what's bothering them. And then you're going to, in your mind, list 3 or 4 or 5 diagnoses and pick out the best one and start to treat the patient after you've made that diagnosis. So this kind of thinking is really important in medical education. And so we go back to these numbers. 9% used to flunk out of medical school because they couldn't deal with that kind of thinking. They couldn't create that kind of approach. Nowadays, it's less than 3%. Now, this is different from law school. This is different from nursing school. This is different from veterinary school. What's going on here? What's going on here is if you get into medical school, you are going to be carried through. There are over 50 schools in the country now that have coaching programs where faculty are assigned to students right off the bat to make sure that they get through. If a school does not have that kind of success in getting students through medical school, they are then dinged by the accrediting agency as being something that they have to fix. So we have a cohort of students that are being carried through medical school. Now the question is, well, how good are they? Are they really so much smarter than we were and work harder than we did? Or are there students that are being carried through who are less really capable? And what's happened now is many schools now have something called a pass-through program where they don't even ask the students to take the medical college achievement test. And all they ask them to do is to finish 4 years of college and perform reasonably in 4 years of college, unrelated to how competitive that college is. So what's happening is there's a cohort of students that are marching through medical school. Not all of them are minority students. There are plenty of white students that are not doing the work that they really need to do to learn to be really good physicians. But certainly we're taking in students that have less academic achievement, and we're doing this on purpose. And the reason we're doing it is because this idea that Black people need to have Black doctors. That's an important thought and theme that's going through medical education these days. I think Black people need to have the best doctors they can get, and I don't care what color they are. So medical education now is specifically saying we're going to reduce our dependence on academic achievement and increase our dependence on people that are active in the community, that have demonstrated resilience, that have demonstrated persistence. I ask you, do you want your surgeon to be resilient, or do you want your surgeon to be knowledgeable when you're on the table? And that's really the question. And I think, in fact, Black patients are not going to really want Black doctors. They're going to want the best doctors. They're not foolish. They know damn well that their best chance for being cured is to have the most capable people caring for them. So what's going on now is this idea that we need to allow people into medical school, not because of their achievements, not because they've been well educated up to that point from the beginning of their grade school time, but rather some students who simply want to be doctors. I think it's great that they want to be doctors, but not everybody should get that. Not everybody should be the pilot that's going to fly me out tomorrow back to Philadelphia. These are tasks, these are jobs that the society needs to have the most capable people. And this doesn't mean that doctors now are not going to be capable, but it means that there's going to be a cohort of physicians who have entered into the profession, have moved through the profession, and just are not up to it. And whether now remember, there's 22,000 physicians a year that graduate from medical school. If it is 1 or 2 or 3% of them that are less capable, that's a lot of people. 3% of 22,000, 600 and something? That's a lot of people. And they're coming out every year, and they're populating American medicine, and it's a real concern. And this, I think we need to get, Heather McDonald has been here and spoken to this audience, and Heather McDonald's famous book, The Diversity Delusion, and it is a delusion. It's a delusion that you can have both complete diversity and not sacrifice merit. It's just impossible. That cannot be done. And it is a physical reality that you have to deal with. And unfortunately, this is what's going on in medical education. So there's a cohort of students that are coming through that I really worry about.
And the flip side of that, the flip side is the number of students who are very qualified who are not being admitted. And we've seen that quite a bit as well. Let me just give you some...
Let me make one other point, though. There's also another flip side, and that's the Black kid who's brilliant and capable and has gone through his education, her education, and has done incredible work and is now moving through the field and entering in the profession and is going to be smeared by this idea that there are other students that are moving through the profession, moving through their training, who aren't qualified as he or she is. And that's just as much of a tragedy as the Asian kid who's a brilliant kid who can't get into medical school. And we, as Christina pointed out, we get lots of letters from parents whose kids can't get into medical school, who got perfect scores in their GPAs, had the highest scores on the medical college achievement test, in the top 5%, can't get into medical school.
Just as an example, there is a test that all medical students take after their second year of medical school. It's called the United States Medical Licensing Exam, and it's tests their knowledge of what they learned in the first 2 years, which are the basics: anatomy, biochemistry, pharmacology, physiology, and so forth. And it's a multiple choice test that's graded by computer. What happened? The computer was called racist. And in January 2022, they dropped the grades for this step 1 exam for licensing altogether and converted it to pass-fail. So this is the impact that this is happening.
And by the way, this test, this first part of the licensure exams, was used by residency programs in order to determine who are the most capable students. And the reason for that is because there's grade inflation. At Harvard Medical School now, over 90% of the students got honors in medicine. Now, they're very smart, but not all of them are honors students. But 90% of the students got honors in medicine. So therefore, when you look at the letters that come from the medical schools to determine whether you want them in your training program, these students, you can't really figure out whether these are really the best students or not. So we use the exam scores. And they were an important way of defining who should be allowed into very competitive training programs. So for example, in ophthalmology, dermatology, radiation therapy, a bunch of specialties really have only very few openings for training, and they need to take the most qualified people. Not anymore, because they're not going to know who the most qualified people are. And the reason they got rid of that score on the exam was simply that minority kids were not getting the best training programs because their scores were too low. So what's the solution? Not to get better kids, to get rid of the scores. And this is sort of a form of insanity, really, when you think about it.
We've obviously come through the COVID problem, and during the COVID problem, we heard many things from the physicians and medical and political people who ran the agencies like WHO, like the CDC, like the NIH, and so forth. And anybody who spoke against that, against these recommendations, whether it had to do with vaccines, whether it had to do with treatments, hydroxychloroquine, other sorts of treatments, these people were called crazy, they were called revolutionaries, they were not listened to, they were really taken down by the public people in charge, the Faucis, the NIH, the CDC, etc. And now, quite a bit later, what are we beginning to find out? The people they said were crazy were actually telling the truth, and the people who were saying they were telling the truth were really hiding a good deal of this data. Now, I'm not trying to be controversial on this, but what I found from it, along with a number of other topics, was that the medical profession was losing its standing in this country, that people were not sure who to trust about this. And this is a real problem. Doctors who wanted to provide treatment that they felt was important and adequate were not allowed to do it in certain hospitals. You were told what you needed to do. This is a whole different time for medicine. And we are all really concerned about this.
Yeah, that was a tough time. I think the problem with COVID is a new disease. Nobody had any experience with it. People were analogizing from other illnesses, other viral diseases. Using vaccines does prevent transmission, but that wasn't the case with this disease. Other illnesses like tuberculosis, wearing masks really does prevent spread, but that's not the case as easily with aerosolized viruses the way COVID was. Many diseases, once you get a case of it, you really are immune for life. That wasn't the case with COVID. People were getting it over and over again. So this basically was a new illness, and what really was terrible here was a bunch of public health physicians decided that it was more important to lie to the people, to create this myth that they knew what they were talking about, when in fact they didn't know what they were talking about. And they still don't know what they're talking about. They still don't know whether the strain is going to appear next week that's going to create all new problems. Nobody really knows about this. And yet their unwillingness to be humble about it was really, I think, a big part of the problem. And whether these alternative treatments would have worked, I mean, there are a lot of studies of it. It's a huge literature. This is the sort of thing we're only going to be able to figure out in retrospect. So I think part of the problem was the politicization of the public health enterprise. And Fauci, did a terrible thing. And the worst thing that he did was he said, you don't need to wear masks, remember? He said, you don't need to wear masks. They're not useful. And the reason he said it was a lie, because he knew there weren't enough masks to go around. He knew that it was important that healthcare workers had the mask. And this was their solution to the problem. That's not the solution to the problem. The solution to the problem is to tell the truth. That people will deal with it. People have dealt with wars. People have dealt with bombings. People have dealt with 9/11. People deal with things and are able to deal with it, and you need to tell people the truth. So I think the particular problem with the COVID story was really this failure of the public health enterprise, and it continues to fail. And by the way, it's one of the most woke enterprises that we have. You remember that in the middle of the COVID epidemic, they said you can't go to synagogue here, you couldn't go in this room to pray, but you could go out and run the streets and scream about Black Lives Matter. Now, Black lives do matter. I mean, that what happened to that man was terrible. But the notion that suddenly we have two kinds of interaction with an illness, one based on your ideology, is insane. It's another example of insanity. It's another example of the craziness that's taken over our country. And this need to be truthful and to need to be brutally honest with the American people is something that we really should expect from our public health officials. We should expect it from all public officials, but politicians are politicians. But the public health officials to not be truthful with us was a terrible, terrible mistake.
Now, by the way, this is not just physicians in medical school. We're talking about research, okay? Research is incredibly important to help advance medical understanding of disease and how to treat disease. These scientists who may be upset with what's going on cannot speak out against it or they'll lose their jobs. So it's just another point I'm trying to make about the way the profession is losing its respect in the public. Now, let's shift to the other area that I would like Dr. Goldfarb to talk about, where I sincerely believe the medical profession is unfortunately being part of the leadership in this effort, and that is in the transsexual, the gender department. This is really concerning, but let me give you a disclaimer first. I have a niece who came out as a lesbian in high school in New York, then married another young woman, and at the age of 30, my niece decided to become a male. So she's what we call an FTM, a female to male transsexual. She underwent the surgery, she went through the whole thing. She made this decision at the age of 30. And I respected that decision. That's her life, and that's the way she chooses it. I also had a niece who at the age of 10 decided that everybody should call her David. And we did. We called her David. She came to bar mitzvahs in a little boy's tuxedo, and everybody just let it happen. And sure enough, she is now 6 months pregnant at the age also of 29 or 30. Teenagers, young kids go through all these things. They are searching for themselves. That is normal. But to have them undergo disfiguring surgery, puberty stoppers, things like that, this has gotten truly, truly out of hand. To the extent, I mean, we've all seen examples, but Glamour magazine had a pregnant man on the cover last month. Go figure, a pregnant man. It's not a pregnant man. It's a pregnant woman. Even though we can't say woman anymore, we have to say person with a vulva. Now, that sounds really silly, but I was president of the International Society for the Study of Women's Sexual Health for 2 years. This society is the largest professional society in the world, multidisciplinary, all kinds of doctors. And the new president, who's been putting out a monthly newsletter, I read with dismay. There was a paragraph that said, "We're so proud of the work we've done worldwide to help people with vulvas." She couldn't say woman. Couldn't say women. So let's get on to this gender thing, and please help us out.
Well, yeah, so right from the beginning of starting our organization, this issue was percolating up. And as I said before, I saw it as related through this issue of treating these children as one sort of cohort and not with an identity rather than as individuals. And first of all, I must say that our organization, our point about this is to totally focus on children. We are not against transgender people. Adults have a right to live their lives the way they want. We're all for that. We have absolutely no concern with people making those decisions. I personally think that these are people who are trouble, mostly, maybe not 100%. But nonetheless, it's really not my business what the adults choose to do. But children, but a 12-year-old child. We have a child that works with us at Do No Harm now, Chloe Cole, who some of you may be aware of. Chloe was 13 years old. She's on the autism spectrum, which she talks about. She was a real tomboy, and she started to transition based on social media. And her parents sort of went along with it. They were very involved in her life, but very concerned about it. At age 14 or so, she started on hormones. She was on puberty blockers. She had her breasts removed at age 15. And now she's 18 years old, and she is a beautiful young woman who realizes that these physicians who encouraged her to do this have ruined her life. She can never breastfeed a child. She may never be able to have children even. She has complications of the surgical procedures that she had with poor wound healing, and she has other problems with her genital tract, and she speaks about these in very clear terms that I think people find to be horrifying. And there's a whole cohort of children like this out there that have started down this path, that have had their, often they call it top surgery. They have a million sort of euphemisms for what they're doing. It's really cutting people's breasts off. That's what it is. And there are many children like this out in the country. And it became clear when we talked to audiences early on, and we met with people that are interested in the whole question of how healthcare is moving forward. They always ask us this question: what are you going to do about these kids? And so we decided to take this on, and we've been, again, sponsoring discussions. We've taken the same model. We've taken the model of trying to inform people as much as possible. We've done some very interesting research focusing on the fact that European countries now Norway, Sweden, Finland, and the United Kingdom, even France, have all said, we've had a long experience with this activity, and we realize that we're probably harming more children than we're helping with this, and they haven't called a full halt, but they've now said that, particularly in Norway and Finland, we're not going to do these procedures anymore except under very strict research protocols. So it's not like 100% ban, but what's going on in the United States, where there are 100 gender clinics, over 100 gender clinics now, and if you go on the websites of some of them, which unfortunately I've had to do, you'll see things like, we do not need a letter from a therapist, a psychotherapist, in order to start you on hormones. All we need is your parents to agree that, and either you're over 18 or your parents agree that you should start on these treatments. And we have no idea what percentage of the children that are starting on this are harmed. We know from some studies from the military that about 30% of people who get these hormones as prescriptions, because the military can keep track of that, about 30% of them stop taking the hormones at some point. So we have no idea if this is a 30% problem, a 50% problem. We just don't know. And meanwhile, in the face of Europe saying this whole activity has really been too potentially harmful to persist in, our country is going full bore saying we should affirm every child. And you heard the President of the United States say any child that comes in, or Rachel Levine, the Assistant Secretary of Health, say that any child that shows up and says, I'm transgender, you should affirm that. You should support that. You should start them on puberty blockers if they need it. Now, puberty blockers are a gateway drug. 95% of the kids who start puberty blockers go on to take hormones. So to say that they're taking it in order to pause is just not true. It's a gateway drug. And the original protocols of this that were developed in the Netherlands, first of all, excluded any kid that had autism, depression, anxiety, a history of abuse, and those were all eliminated. So the kids that they treated were these very high-functioning kids that had been gender dysphoric, which is the term for the condition, their whole lives, really, from the earliest time anybody knew them. And even these kids, it's very unclear whether they benefited at all from going through that. And what's happened in the United States, as you probably are aware, is the cohort that's going through this now is quite different. It's mostly young girls. It's not boys. It used to be mostly boys. It's young girls, and they develop this condition called rapid onset gender dysphoria. They first manifest this desire when they're like 13, 14 years old. And they've never expressed any of these interests before. And so what happens? They've either had a friend who's gone through this, they're unhappy with their bodies, they're starting to go through puberty, it's very uncomfortable, they're starting to have their periods, they hate that. And what are they doing? They're going to their guidance counselor, or they're going to a doctor who's saying, yeah, their pediatrician saying, yeah, this is a good idea because the medical societies have been supporting this. And now you have a situation in which you have this unhappy child who suddenly is given this pathway that's supposedly going to make them happy. So their parents that they may have been in conflict with over this new decision that they've made, now their parents are going to support them because their parents have been told, if you don't let your child do this, you're going to have a dead child. You're going to either have a dead son or a live daughter or vice versa, which is not true, by the way. It's totally untrue. So this has become a real epidemic in the United States. Supposedly there are about 300,000 kids now that are in various stages of going through these protocols. And so what's the solution to it? Our solution, the ideal solution, is for the medical establishment, as these countries in Europe have done, and said, let's look at this carefully and let's now decide whether this represents ethical care, whether this is an appropriate treatment. We used to do lobotomies to improve people's mental outlooks. That was a physician won the Nobel Prize in Medicine for developing lobotomies back in the 20s. We don't do that anymore because it turned out that we were destroying people's lives. We weren't helping them. Well, we hope that that becomes the path for this. Unfortunately, in this situation, the medical societies, the Endocrine Society, the American Academy of Pediatrics, they've decided they're going to go full bore in this. They don't want to hear anything about this. They put out guidelines that have been reviewed and have felt to be of very, very poor quality in terms of the evidence that they're beneficial. And this is what's going on. So therefore, we've had to go down the path of the government intervening, and we've sponsored legislation in a number of states that says this is illegal. You cannot do this to children. And now these laws are going to be challenged in the courts. There's one passed in Tennessee, there's one passed in Missouri, Kansas. Florida has been very prominent in doing this, and right now this is a big battle in this country. And I'm telling you, this is going to be a big issue in this presidential campaign. If anybody is wise enough to point out that a government that supports this activity and a scientific community that supports this activity without the scientific basis to justify it is really one that should not be in power. And I think, you know, harming these children is just an awful thing. And again, it has nothing to do with adults. It has nothing to do with being transphobe. It has to do with saying this is a condition that's developed in children. We don't know which children will benefit from this, and therefore it should not occur to these children.
Two things I want to point out. First of all, I've listened to Chloe speak, and what I was amazed in listening to her was the fact that she said she got so much support to do this from school, from her guidance counselors, from her parents. This is what we frighten these people. If you don't go along with this, she's going to commit suicide, which, as Dr. Goldfarb said, is not true statistically. But she felt she was encouraged so much, and now on her way back to detransitioning, which body of people is starting to be larger and larger that we're seeing, she regrets that she didn't get the guidance, that somebody didn't say, don't do this, and if you wish to do this, let's wait and give you some time.
Just to show how corrupt the medical societies have been on this topic, is that the Endocrine Society, the American Academy of Pediatrics, refused to put together a set of guidelines for how you treat the detransitioners. They refused to put a set of guidelines in place. Even though their guidelines are purely based on opinion, they're not based on scientific data, they wouldn't even try to help these kids because they don't want to acknowledge the fact that there is a cohort of individuals that have gone through this pathway and have been so injured by it.
And the second thing I wanted to point out, we use the term affirmation therapy. And I really want to make you understand what that means. This is from the American Association of Psychiatrists, the College of Psychiatry, the psychologists, all the professional organizations. Affirmation therapy means that when a person walks into your office, and we're specifically talking about young people, and says that I feel I'm not the gender that I've been called, you must affirm that decision, okay? You have to affirm it and say, okay, where do we go from here? How can I help you? And so forth. No longer are you supposed to do exploratory therapy, which any good psychologist or psychiatrist would say, okay, great, I hear you, let's sit down, tell me about what brought you to this decision. And even if you got to a point with something called conversion therapy, that is verboten at this point. You are not allowed to sit down with a young patient and say, let's see if we can get you back to where you were. Affirmation therapy means you are doing what the patient wants, what the young child wants, and you cannot counter it at all. That's outrageous.
And one of the real tragedies here is the fact that for years, when these children with gender dysphoria, before these treatments were available, were studied, the vast majority of them went on to lead normal lives. Some of them were gay, some of them were bisexual, some of them were heterosexual, what have you, but they weren't mutilated and they weren't damaged and their reproductive capacities weren't altered and their ability to have sexual pleasure was not eliminated by these various medical treatments. So again, the point is puberty is a part of development. You need to go through puberty. Without going through puberty development, there are medical, physiological problems in terms of bone health, in terms of psychological development, but more so, even the ideas that are developed through going through puberty are ideas that allow people to become normal human beings. It's an important stage of development, and these kids are being denied that.
I would like to open up the floor to questions. Please, Ellie, stand up. I'll come.
I happen to be a card-carrying member of Endocrine Society. I said I happen to be a card-carrying member of Endocrine Society. Fortunately, I retired a number of years ago. I don't know what I would do if one of these people would make an appointment to come to my office, and I really don't believe that they deserve what they want. I know from previous experiences that all these drugs are available on the street, no different than marijuana and amphetamines. Anything you want, you can buy. But there's a lot of pressure now on doctors to treat people, even though they don't believe that that should be done. What's your feeling on that?
Yeah, you know, we have 2 endocrinologists that work with us now as senior fellows who do no harm. Matter of fact, we had a booth at the Endocrine Society meeting for Do No Harm, where many endocrinologists, we're writing up the experience. I wasn't there, but we're writing up the experience that our endocrinologist, Dr. Roy Eapen from Canada, and Dr. Dan Weiss, who lives out in, I guess, Utah right now. They interacted with many physicians who came. Some of them expressed, the European endocrinologists said, you know, what's going on here? They really were quite surprised at the way the United States was treating this. Some people just weren't that familiar with the whole issue. And then others were quite upset with having this group saying that this activity was unacceptable. We're trying to ask the Endocrine Society to do a systematic review. And the reason we're trying to get them to do that is because right now, these laws that have been passed are going to be challenged in the courts. And the judges are going to look at the challenge and say, what do you want me to do? Here's the Endocrine Society, here's the American Academy of Pediatrics, all these huge old professional organizations are all for this treatment. You know, why are you telling me that this is a bad thing? We think if we can get at least the Endocrine Society, which is mostly adults, and to get them to say, let's just look at the literature, let's look at the science, because when these countries have stopped, like Finland, Norway, UK, and Belgium, and have all, the reason that they've stopped giving these treatments is because they've looked at the literature and said, there really is no valid evidence here that this is benefiting these kids. We're trying to get the Endocrine Society to do that. It's a huge problem, and I think, you know, the 2 physicians we have working with us, they treated people that were transgender people, and they've stopped. Dr. Eapen stopped doing it because he said they were just as miserable after I started them on these treatments as they were before. And all their psychological problems didn't go away. You can't cure a psychiatric problem with surgery. And so some people are just refusing to care for these patients, and others have made this is their career. It's a $1.9 billion industry right now, according to some healthcare claims.
But as a position of being a physician who doesn't feel that he would or she should want to treat these people, there's a lot of pressure on doctors to see everybody that comes through the door, because in the world of insurance companies, all doctors are interchangeable. So you can't. What does the doctor do?
Well, you know, there are laws now being proposed in states, laws of conscience, where physicians are not going to have to practice, do things in medical care. Often it relates to abortion, that they just don't believe are valid procedures. It's a very tough problem, no question about it. And I think you know, what's required is a lot of empathy, a lot of attempt to understand things, a lot of, if a patient demands it, a family demands it, try to guide them as best you can. One of our members, Miriam Grossman, is a psychiatrist who's written a book now that is just about to come out. It's guidance for parents, what to do when your child shows up and makes these sort of requests. But I think it is a very serious problem to have a treatment that is being forced on people, forced on doctors to use. And I think it's fair to say, I can't do that. I can't do that. And you can find another physician that might do that, but I can't do that for you.
Next question.
Bruce Berger. So all these medical associations are headed by doctors who went through school before woke medicine. What is their impetus to be caving into this? Is it the funding that comes from the government? why are they doing this when they weren't brought up or educated in this area?
Yeah, you know, it's the origins of sort of woke mentality, which kind of folds into this, are interesting. I think as far as the societies go, you know, there's two aspects to these societies. They have a governance and they have a management. The management are full-time people, staff people. The governance are academic physicians mostly, not exclusively, who then get elected every few years to be on councils and to be on boards. And I think that what happens is the staff is the ones who are really pushing this. The other thing that's happened, and the governance people sort of, you know, they have other jobs as well. And do you really want to start a fight that's going to be a bloody fight when you've just been installed as president of the society? Or you're going to try to get through the next 2 years without everything coming down on your head because you've decided to be the one person who steps up to fight against something you don't believe in. The other part of this is, let's say that you go back to the Endocrine Society 10 years ago, let's say, when they were first proposing to create guidelines for this. What do? You go find out who in your society is actually treating these patients. So you ask them to be the ones who write the guidelines. You want someone who has experience as well as expertise. And often it's turned out that these people are activists. And so the activists have sort of taken over. There are a few physicians. There's one at Mount Sinai. His name is Jonathan Safir, who's the one who's pushed the Endocrine Society very hard to be, foursquare behind this. The AMA just came out with a new resolution coming foursquare behind gender-affirming care. So the politics of it are complicated. These people now have become experts. They're well known for their advocacy. They're getting a lot of publicity. They're getting a lot of money, frankly, in order to continue in this activity. And so there's a corruption that's going on. You know, the old story, it starts out as a cause, it becomes a business, and it turns out to be a racket. And this is what's going on in this field.
I would like to end the event, but invite you to come up to Dr. Goldfarb to ask questions. We've barely covered all of this, and Heather McDonald will continue with this kind of discussion in a couple of weeks as well, in July. I really want to thank Dr. Goldfarb and Christina Rasmussen for the work that they're doing in defending the profession and defending these young children. It's a very, very difficult process. Please go to the website, Do No Harm. And if you feel like it, please contribute to that. You know, Dr. Goldfarb does not get paid. He does this gratis, and we respect that gratefully. So I would like you to come up and ask questions, but I really want to thank Dr. Goldfarb and thank you all for coming. We hope to see you here again.
By the way, our website is donoharmmedicine.org. It's one word, so please visit it. It's quite a website.